Welcome to the Institute for Work and Health speaker series. My name is Monique Gignac. I am a scientific director and senior scientist at the Institute. Before I introduce our speakers, and we're lucky today to have two speakers with us, I'd like to just go through a little bit of the housekeeping. What we do usually for our speaker series is if this is your first time joining us, is that the presenters will go through everything. The presentation will be posted and the slides will be made available usually in about a week. We hold questions until the end of the presentation, and we ask that you type your question into the question and answer box that you'll find on the bottom of your screen. If you would like to use closed captioning during the presentation, you can usually find that under the More key. You'll see the closed captioning there. So we usually get a lot of questions, and I'm hoping we're going to get a lot of questions and comments from you today as well. So what I usually try to do is package them, make similar questions I'll present together. But if I don't get a chance to ask your question, please do contact the speakers who would be absolutely delighted to answer it for you offline once we're finished the presentation. So again, questions, please do type them out in the question and answer box. And I think we'll get started now. It's my very great pleasure to introduce Dr. Basak Yanar and Dr. Cameron Mustard as our speakers today. Dr. Yanar is a scientist at the Institute for Work and Health and an assistant professor in the Dalla Lana School of Public Health at the University of Toronto. She holds a PhD in organizational behavior and human resource management from the Rotman School of Management at the University of Toronto, and her research focuses on migration, work, and occupational health and safety. Her current program of research explores workplace health and safety within the context of linguistic and cultural diversity and how employers can foster inclusive safety practices. Dr. Cameron Mustard, as many of you know, is the former president and a senior scientist at the Institute for Work and Health, retiring in January 2022 after 20 years in the position. He continues his affiliation with the Institute as an adjunct faculty member. Cameron is also a professor in the Dalla Lana School of Public Health at the University of Toronto, and his research interests include work environments, labor market experiences in health, and the epidemiology of socioeconomic health inequalities across the human life course. So welcome to both of you, and I will turn it over to you today to discuss employer perspectives on supporting public safety and personnel's return to work after post-traumatic stress injuries. Thank you.
Thank you very much, Monique. And we would like to thank everybody who are in attendance today. And as Monique mentioned, Cam and I will be presenting a recently completed qualitative study on employer perspectives on supporting public safety personnel's return to work after post-traumatic stress injuries. I would like to acknowledge our research team, especially Leslie, who was our project coordinator, for her contribution to this project, as well as we really would like to thank the participants of our study for their time and engagement on this project and their valuable insights. We have a summary report of our study published on IWH website, and I think Sabrina will be sharing it on the chat box as well, if you would like to take a closer look at our study findings. So I wanted to start our presentation with some of the key insights that we would like to leave you with, and I will be presenting these a little bit more deeper in my presentation, but there are a number of insights that we thought we would want to share right away with you so that you have an idea about what we're going to be talking about. Post-traumatic stress injury is a complex occupational injury which requires timely access to mental health support and organizational initiatives that focus on supporting public safety personnel. We conducted our study with public safety employer representatives, and public safety employers have a maturing recognition of the challenges in supporting and accommodating public safety personnel with PTSI, and are implementing a range of internal practices to respond to these challenges. And I will be talking about these practices that they mentioned in my presentation. Public safety employers emphasize the need for return to work processes that focus on reintegration, which includes collaboration of all stakeholders, flexibility and creativity in accommodations, and social support. Public safety employers also express a strengthened recognition of gradual return to work and modified work role as an important component of treatment and recovery. And they also discuss preventive approaches needed to promote mental health and building trust with public safety personnel as vital to preventive care, and return to work. So I will turn it over to Cam for providing you with a background of our study, and then I will take it over again and walk you through our findings.
Thank you, Basak, and welcome to everyone who's joining us in this presentation. So I'm just going to make a few comments by way of context for those of us perhaps who aren't as familiar with our public safety organizations in Ontario. So one important observation here is that as of 2016, a diagnosis of PTSD in a first responder is designated to be presumptive. In other words, it's designated by the WSIB to have been caused by work. So following the presumptive designation in 2016, we currently see in Ontario somewhere between 1,200 and 1,400 accepted compensation claims annually in the province among first responders with a PTSD diagnosis. Importantly, the claim durations among first responders disabled by PTSD are long. Approximately 40% of people with an accepted compensation claim are on benefits for 2 years or longer. I think over the last 5 years, there was a recognition that there was limited mental health treatment capacity to meet the specific first responders with PTSD. And one response to this recognition was the establishment of a specialty mental health treatment program in 2021, delivered by Trillium Health Partners, that is exclusively for first responders with a work-related mental health disorder with a capacity to treat somewhere between 400 to 500 first responders annually. And Basak and I, with colleagues at the Institute for Better Health, completed a formative evaluation of the mental health treatment program over the period of 2022 to 2024. One part of that evaluation was a series of very valuable conversations with representatives of public safety employer organizations about their practices and challenges in supporting recovery and return to work among their members disabled by a work-related mental health disorder. Can I have the next slide, Bishop? The one thing I'd like to point to in this table, maybe two things. The number of first responders in Ontario across fire services, EMS services, police, and corrections is somewhere in the neighborhood of 60 to 70,000 people. And if you turn your eye to the bottom row in this table, which is reporting the incident rate for PTSI, post-traumatic stress injuries, per 1,000 person years, EMS, police, and corrections, the incident rate here is the equivalent of 1 case for every 100 person years, which is very high. And I think that's the important context here, that 1 out of every 100 first responders in a typical year is going to be disabled by a work-related post-traumatic stress injury. Basak, it's back to you.
Thank you, Cam. So our research objective, as Cam mentioned, was to understand employer perspectives and experiences on supporting return to work among public safety personnel who experience post-traumatic stress injuries. And for the remainder of the presentation, I will be using PSP and PTSI as the acronyms. And we define PTSI as a non-clinical term that encompasses a range of mental health injuries, including some operational stress injuries, clinically diagnosed post-traumatic stress disorder, anxiety, and depression. So we conducted 39 interviews with 45 representatives. So a number of interviews were conducted with dyads from the same organization who were employed by a public safety employer organization in Ontario, which includes fire, EMS, police, and correction. And our recruitment numbers were distributed across these 4 services to approximately proportional to the employment count in each sector. And we recruited individuals from 28 employer organizations. The individuals who participated in our interviews had knowledge and experience with disability management and accommodation policies and practices, specifically relating to mental health injuries. Employer representatives worked in various organizational departments, including human resources, claims and wellness, and executive leadership. Given the active role unions and associations play in supporting the return to work process, mediating the relationships between employers and PSPs, we also spoke with union and association representatives who had experience and knowledge in disability management and supporting return to work. So their interviews helped us have a broader understanding. Our interviews focused on the process of creating a return to work plan, return to work processes, exploring the roles and relationships with the stakeholders involved, organizational considerations in developing a return to work plan and common challenges. And also our participants talked about some of the preventive measures and their practices around successful return to work. So in the remainder of the presentation, I will give you a brief overview of some of the broad themes and challenges related to return to work that were discussed in our interviews. And then I will focus mainly on organizational practices that were shared by our participants to improve return to work, which included current practices and some aspirations. So due to our time constraints, we have a lot of data and we don't have much time to cover them, all of our information. So I will briefly touch upon these themes, but I will be very happy to discuss more during the Q&A if you have more questions. So in our conversations in our interviews, we identified 4 broader themes and challenges related to return to work that speaks to PTSI as a complex and individualized injury, organizational factors that influence return to work, and collaboration among stakeholders in facilitating return to work, and also communication and trust came out as a broader theme as foundational for successful return to work. Employer and association representatives reflected that PTSI is common among PSP, noting that they are regularly exposed to unpredictable environments and potentially traumatic events. They acknowledge PTSI as a complex, individualized injury that does not have a set prognosis and tends to take longer to return to work from. Participants understood PTSI as an ongoing injury whose impact fluctuates over time and presents differently in each individual, hence requiring ongoing flexibility and support. Employee representatives expressed the importance of PSP having timely access to healthcare providers in preventing PTSI and reducing long-term severity. And they mentioned that PSPs need mental health professionals who are knowledgeable of their profession and aware of the resources and possible accommodations specific to their organizations. However, they talked about limited access to mental health assessment and services. In the context of conversations around PTSI, participants also talked about the mental health stigma within their organizations that related to PTSI that can deter PSPs from accessing mental health support or reporting their challenges with mental health. They explained that there was historic mental stigma within the organizations, but it's slowly diminishing throughout the public safety organizations, mainly attributed to broader societal changes related to mental health and legislative reforms that define PTSI as an occupational injury. Representatives acknowledged that the remnants of this historic stigma still exist within their organization due to discrepancy between organizational processes and messaging. And also they talked about some of the internal capacity challenges related to recognizing and management of PTSI. Participants also discussed factors inside the workplace, recognizing that organizational challenges such as staffing shortages or low budget limited their resources, and that could pose challenges for the return to work process. They spoke about limited human resources to manage PTSI claims. Many employer representatives said that they manage a high volume of various types of claims, which required a lot of time and effort to coordinate and maintain communication among all stakeholders and keep track of the progress of claims and supports unique to the PSP's limitations in the return to work process. One factor that affected the available accommodations was organizational size. Larger services tended to have more accommodation options that they could offer to PSP. And also diversity of the potential accommodations at time depending on the public safety profession. Some professions may have more specialized work such as corrections and paramedics. So they talked about some of these challenges in terms of identifying options for meaningful accommodations. Employer representatives also explained that they collaborate with the WSIB, with community mental health providers and associations and unions in the return to work process, and the actions and the policies and the challenges of each stakeholder influence the return to work process. Overall, they discussed a number of challenges related to insufficient information they received from healthcare providers related to members' limitations and functional abilities, which limited possible accommodations. They were in generally of the view that some healthcare providers providing clinical care, they needed to have intimate knowledge of the professions, and expressed concerns that this may not be consistent among treating community mental health care providers. They also talked about challenges related to healthcare providers and WSIB case managers' limited understanding of modified work roles and accommodations that public safety organizations can provide, and expressed the concern that this lack of knowledge and available accommodations can prolong the return to work process. And they also described challenges related to communication with WSIB case managers, especially concerning the recovery status of the individual member, and these frequency of updates and the quality of limitations and restrictions overall influence the degree employers can support PSP in returning back to work. They mentioned that they don't need the full medical report, but it was important for them to have the details of the capabilities, limitations, and restrictions. And overall, employers talked about in our conversations a broader theme of communication and trust as foundational for successful return to work emerged. Participants acknowledged that there was historic lack of trust between employers and PSPs, explaining that PSPs felt unsupported by their organizations and reflected needing to foster a trusting relationship with PSPs by investing in more preventive supports, leading with empathy and training on PTSI and accommodations. And they talk about a dialectical relationship between trust and communication when the level of trust impacts degree of communication and vice versa. And they also noted that they wanted to take a more active role in communicating with PSPs. So in the remainder of my presentation, I will be mainly focusing on what we heard from our participants in terms of some of the organizational practices that they have within their organization to improve return to work outcome. Basically what we did, because we had a list of practices that they talked about, so we categorized them into 4 categories for you to, and I will be explaining them more in detail in the following slides. So some of the practices really spoke to strengthening their organizational capacity for prevention of mental health and also improving return to work, tailoring return to work to process to meet the complexity of PTSI and the needs of the PSPs, supporting organizational processes through third parties and stakeholders, and also they talked about some practices that are related to managing external stakeholder relations to improve return to work. So they described initiatives to increase their organizational capacity to meet the needs of PSP. So employer and union representatives mentioned that claim management work is specialized, and they described the importance of bringing in staff who have expertise in HR, wellness, and abilities management, who can bring in new and creative perspectives to the organization, effectively support PSPs, and build trust, building trusting relationship with PSPs. Especially association representatives stressed the importance of having abilities management staff who are compassionate and knowledgeable about PTSI. Employer representatives shared either having a dedicated team for claims management or aspiring to have such a team. Not all organizations did have these wellness and ability management teams, and one of the reasons they mentioned was the funding. Also, hiring specialized mental health personnel, such as staff psychologists, was discussed, where PSPs met with a staff psychologist prior to entering the position, to establish a mental health baseline, or meeting with them regularly to ensure mental health remained consistent. Participants described bringing mental health expertise into the organization that can help guide the various preventive mental health initiatives, allow timely access to psychological supports, and educate healthcare providers they regularly work with on their organization. And some employers basically discussed training programs, education initiatives for supervisors and staff. Training for supervisors included their role in supporting PSP's mental health, building competencies around working with others experiencing PTSI, duty to accommodate, understanding limitations and supporting PSP. Especially as related to the mental health stigma that I mentioned, they talked about educating supervisors and management on mental health and mental health advocacy. Staff education mainly focused on self-care, recognizing signs and symptoms of mental health challenges. They also talked about safeguard programs that also included mental health support, attendance tracking, debriefing after difficult calls, or peer support. So this is a lengthy code, but I think it provides a good example. So one fire employer mentioned, once we understand that they're considering or getting close to return to work, peer support reaches out right away. They set up a meeting with the employee with us, and they say, okay, you're going to have a meeting with management shortly to talk about return to work. This is what the process looks like. Here's what they are going to say. Here's the questions. And then we meet with the employee and the peer support member who has been assigned to that employee. Then we start to talk about return to work. When they return to work, that person is assigned to them as their buddy, their supporter, their advocate, their person that they can talk to as they go through that process. So this is an example from a fire employer in using peer support. Participants also acknowledge that PTSI is complex, that requires support that is tailored to the unique needs of the PSP. And so they describe certain processes and systems that included more tailored approaches. Some participants from across all sectors described the importance of having a reintegration program focused on understanding PSP's needs and tailoring the pace and duties of return to work to meet these needs. The organizations were in different stages in establishing these programs. Some already had these programs, some were in the process of establishing them, and some aspired to have these programs. But PSP's the individualized support began when PSP went off work, where a participant describes speaking with the PSP about how often they would like to be contacted, by whom and how, trying to meet these needs while being transparent about the organization's limitation. They talk about a plan that gradually increases hours and exposure to pre-injury role at a pace that is negotiated with PSP, as PSPs may have different activators that employers need to take time to learn. Employer union and association representatives, they all talk about, they also mentioned that the process for reintegrating the injured PSP back to work could feel overwhelming for the injured worker, especially after a long absence. So they may need to go on regular occupational training, professional development, and social integration. So they talked about the need for highlighting the importance of PSP being informed about the changes in staff and management and potential cues that may be present in the environment before entering the workplace. Some employers, so that's kind of, that was the point that I wanted to make, graduated return to work with the recognition that can be overwhelming. So this is a quote from the AMS employer talking about meeting the needs of the worker. So the current process is that if your note says once you're certified, you can do 2 shifts a week, 6 hours a shift, writing third for 2 seats, and then we can bump up to 8. Whatever it says, then we work with the person individually to find them somebody that they can feel comfortable with and that it can be somewhat consistent, because they don't want to write with a different person every day. They don't want to tell their story to half of the service because it's none of their business. We've found that we definitely see better progress and more success if the medic gets to choose someone that they feel comfortable with. So supporting return to work of PSP is a team effort that involves multiple stakeholders, including WSIB and healthcare providers. As I discussed earlier, employer organizations may face communication and case management barriers with these stakeholders. And in our conversation, they discussed practices that they engage in relationship to these stakeholders to improve the efficiency and effectiveness of return to work process. A number of participants talked about educating their WSIB and healthcare providers by offering by sending them a list of possible accommodations and supports that they provide. They highlighted the helpfulness of having a dedicated return to work specialist within WSIB actually for their organization who can train on their profession and organizational conditions and accommodations. A number of representatives described inviting healthcare providers into their organization to build knowledge of the prevention and their working environment and possible accommodations. To support the treatment of PSP, a number of organizations mentioned they give healthcare providers the option to do exposure therapy in their workplace. So these initiatives were specifically extended to occupational therapists whose role in treatment was more practical. A number of representatives discussed various ways of improving communication and encouraging more active case management by WSIB. They described encouraging WSIB to consider expanding PSP's circle of care by referring them to different specialists and thinking about different modalities. Given employers do not have access to health information, they offered WSIB case managers with general suggestions in terms of for care in hopes that that would spark some discussions. Some employer representatives encouraged treatment assessment by voicing their concerns and suggestions to case managers, escalating concerns to supervisors, and encouraging a second review of files. So a police employer talked about kind of like, engaging with the WSIB and the clinicians. Part of the issue sometimes is physicians don't have an understanding of exactly what a police officer does and how they can be accommodated in the workplace. So they see a police officer that is running from call to call to call, not having a break, just constantly on the go. But they don't have the understanding that that's not the only way somebody can work as a police officer. One of the things that we're doing is that we provide WSIB and clinicians information about our reintegration program and share with clinicians we have this program in place when this person or when this employee is ready to return. Consider utilizing our facilities to expose that member back to the workplace. We try to do a better job from our end of communicating through the WSIB to the clinicians. They also talked about supporting their own organizational processes through third parties and stakeholders. So, for example, some participants talked about contracting a third-party disability management company to support the management claim process. For example, another organization mentioned consulting with an HR specialist on best practices for effectively managing and supporting claims to return to work. A number of participants sought the guidance and expertise of healthcare providers in their community. They contracted these providers in their area to provide transitional mental health support for PSPs who are struggling to find permanent healthcare providers. Also, organizations from police, fire, and paramedics who were administratively integrated within a municipality and correctional institutions where they were integrated within the Ontario Public Service collaborated with these organizations, municipality or OPS, to find appropriate accommodations when the PSP was unable to be accommodated within their organizations. This was especially beneficial in situations where PSP is permanently unable to return to work on their pre-injury job. Also, participants shared that the unions and associations play an important role in facilitating relationship between employer and PSP, and they noted that PSPs tended to trust their associations given their role as their support. So they shared that PSPs they utilize this important role in having union representatives participate in return to work planning. And of course, this depended on the relationship or PSP's preference. So this is a corrections employer talking about utilizing the relationship with the unions. Whenever there is an accommodation that needs to be implemented, we have medical information, but we also have a union rep and a program this is the name of the program that we took out for privacy. Program trained person, manager, and the employees sit down together. And when they are creating a specific accommodation plan, it is collaborative. So the union has buy-in, the manager, the union member, the employer, and another representative, which is usually another union member. They sit together collaboratively and they figure out what accommodations are going to work best. I think the union is very helpful when it comes to that aspect, only because by nature, if management might suggest something, there may be some pushback. But if the employee sees the union and management are in agreement with this, is the accommodation plan that we're going to roll with, then there's not much resistance to it. So, these are the points that I have made earlier on in our, some of the key insights that we wanted to leave you with. And I think I will stop at that because we're a half-hour mark. And thank you very much.
Thank you very much, Basak and Cam. We'll open it up for questions. We don't have a lot of questions at the moment, so please do add some questions and comments, and I will ask them of our speakers. I do have a couple, though, for you to start us off, and while other people are thinking of what they would like to ask. First of all, you mentioned one of the themes being around communication,
Yes.
and that was a challenge. Could you be more specific? Like, what was the problems? Were people not communicating? Was it not enough or not at the right time? Are there things people were doing about it? So can you talk a little bit more in detail about communication?
Yes, sure. So I think one of the things that I mentioned in the communication theme that, well, communication is a challenge because a number of things that participants mentioned that it really depends on public safety personnel and their preferences in terms of whether they would be like to be communicated or not. So I think that was a challenge in terms of figuring out that kind of sweet spot, right? And a number of, representatives talked about that they needed to find out whether the worker would, how much they would like to be contacted, how often they would like to be communicated. And we heard that, like, for example, there were a number of practices that they mentioned that they use in terms of figuring out some innovative practices, for example, asking PSP, who would you like to contact you? How would you like to be contacted? Just as that. But as I mentioned early on, there has been some lack of trust between the PSP and the organization. And we hear that whether it's related to mental health stigma, whether the erosion of the relationship between the PSP and the employer, sometimes we heard that PSP could go off work and there would be no way of contacting them, or the PSP would actually not want to be contacted. So I think there were a number of things that we heard. It was an important theme. One is the lack of communication due to some of these challenges that I mentioned. And the other one is actually preference of the public safety personnel, whether they would like to be contacted or not. So those are a few things that comes to mind right away in terms of the communication.
Okay, thank you. We do have a number of questions coming in now. This one maybe I could ask of you, Cam, because it refers to some of those original slides. You noted that PTSI diagnosis is presumptive for first responders. We have someone asking, can you tell us what that means? What do you mean by presumptive?
Oh, good question. Good question. So in 2016, the WSIB amended an aspect of benefit administration legislation to declare that if a worker in a public safety role is diagnosed with a mental health disorder, typically PTSD, that the compensation process assumes that the disorder was caused by work. So it is not necessary for the worker or the employer to make the case, to provide the backstory, if you will, as to how this disorder was caused by work. It's presumed by the compensation authority that it was caused by work. And prior to the presumptive designation, 2014, 2015, there might have been about 100 accepted compensation claims among first responders for work-related mental health disorder. After the designation, almost immediately, the volume went up to 800, 900, 1,000. So that, I hope that clarifies it.
Yes.
Okay. Thanks.
Thank you. Another question. You gave some quotes, Basak, of sort of this collaborative process, a lot of people who were involved. But were there responses from some of your participants on the challenges or the risks and maybe having too many hands in the pot, as this person is saying, when you've got 4 to 5 people who are all involved in return to work planning? Did this make it better, harder, easier?
I think one of the challenges that we heard is actually not so much too many people, but I think more around challenges related to the consistency of the people who are involved within within the return to work. So there were, especially this is true for long term, like, when person is off long term, employers talked about, like, their contacts at WSIB constantly, like, changing, and also not being able to have communication with healthcare providers, as I mentioned. So I think in terms of that collaborative process, those were more of the challenges that were discussed, right? So one of the things that the employer talked about is the importance of that kind of having a unified kind of almost like, goal from their perspective to return the employee back to work, and having that kind of like, almost coordinated effort between all the stakeholders involved. And as I presented in my slides, some of that communication, barriers were related to not being able to have consistent communication with WSIB, or not being able to receive the information. So I think that was more around that, the consistency of the people involved, and also I think communication challenges happening when, from the different parties. So, and then especially I mentioned that, like, they talked about having union involvement as, if there are good relationships, of course, as an advantage. So I think that's like mainly what we have heard related to kind of who is involved in these conversations.
Okay, thank you.
Mhm.
You mentioned special training that,
Right.
often they had to hire people who had specialized training, or that
Right.
there was a need for special training. Was there a sense from participants that this training existed elsewhere and they could just send people off to it? Or were they having to develop some of these trainings for various staff as they were going along for programs?
Yeah, I think we did definitely hear about, and we heard about certain specific programs that were mentioned in terms of providing training. Our participants might attendees might recognize, like, wounded warriors, or like boots on the ground. So they mentioned these organizations that could provide training and supports to their workers, and that's kind of like sometimes they brought in these providers to their organization to provide these trainings. But I think, as I mentioned in my presentation, that there was this aspiration to increase the organizational capacity through bringing people who are knowledgeable about PTSI, mental health, and have the capacity to increase that kind of capacity within their organization, right? So, but one thing that comes to mind that actually participants talked about was, for example, increasing the resiliency training, the need for that, right? And that would basically more of a preventive efforts, especially around training in mental health. Organizations did not have the capacity within the organization, so they talked about, like, having or trying to find providers to kind of provide that kind of training.
Okay, thank you. We have lots of questions. So if we don't get to your question, please do reach out to Basak and Cam for an answer. But let me keep going. We'll see how far we get. There are several questions about trust. And in this case, not so much trust with the worker and others, but trust between some of the other parties that are working together. So between employers and unions, between managers and health and safety individuals. Did your participants talk about strategies that these groups can help to build trust among one another? So, for example, there is a history often with with organizations and unions, and so sometimes that history of pushing back seems to rise to the fore. Any tips that your participants gave in how to handle building relationships?
Yeah, so in our conversations, mainly trust was mentioned by especially employer representatives in the context of the relationship between PSB and the employer, especially like, workers, there's kind of lack of trust with the organization, and for a number of reasons, as I mentioned, in terms of like not being taken care of. But in terms of the trust between other parties, definitely we have heard the importance of good relationships between the unions and the employer organizations. And as I mentioned, a number of participants, they acknowledged the important role played by the union, but we heard that also this kind of engagement really dependent on one, the worker's preference, but also at the same time, it can be impacted by the relationship between the employer organization and the unions. In terms of like what you're asking about establishing that trust, one of the things that we have heard is about, like, this didn't come up as a big theme, but I think in the conversations, the key to kind of like, having that successful return to work process, maybe this speaks to trust, is having that kind of common goal of supporting the worker and the goal of like, seeing return to work as part of the process of like, recovery from the employer's perspectives. And I think there could be sometimes therapeutic tensions between, for example, healthcare providers' perception of, they focus on more full recovery, and the employers might be having a different perspective. So I think these kind of differences in these, the paradigms or the perspectives can challenge the relationship, but it wasn't discussed in the context of trust. But I think that kind of creates some of those tensions, right?
Mhm.
Yeah.
Okay, thank you. Were there any subgroup differences? You had several different types of first responders, public safety personnel. Any differences that were emerging amongst them?
Yeah, that's a good question.
Basak, I might just
Sure,
take a bit of a crack at this.
absolutely.
For a number of reasons, there seem to be some important differences between EMS services and fire, police, and correction. And what are those differences? Well, EMS services are essentially operated by and large by municipalities, and so as Basak mentioned, there seem to be more range of accommodation options among EMS services. So I remember a wonderful story, at least I thought it was a wonderful story, of a municipality that operated an EMS service, as well as many municipalities do, a long-term care facility. And an accommodation was arranged for a qualified EMS member to return to work in a long-term care facility for a period of time and recovery. I think that kind of wonderfully appropriate accommodation isn't as often available to a fire, police, or corrections service. The other thing that I think we saw was, because EMS staff are paramedical, there was among staff more of a recognition of essentially the validity of a mental health disorder, what its symptoms are. And so I think more recognition to some degree within EMS services that these conditions are real and that they can be caused by work. So Basak, you may want to add something to that.
Maybe there's one other thing that I can add, and this speaks to, I didn't, touch it upon because of the time constraints, but one of the things that came up around accommodations and modified duties was around the public safety personnel's identification with their profession, right? So finding the work meaningful. And we heard that actually for police, there's a really strong sense of identity, professional identity, being a police officer. And I think one of the things that that was a challenge, discussed by some of the organizations in terms of challenges of modified duties and accommodation being perceived as meaningful work, or the sense of feeling like if accommodated work kind of challenges that kind of aspect of like identification as a police officer, especially when the employee cannot do some of the pre-injury roles that they held. Yeah.
Okay, lots of questions coming in, so thank you. I'll move on to another one. Cam, at the beginning of the presentation, you mentioned that these claims are often quite long. for people. And so someone is asking about whether or not there is a way, like, is that just the way this is going to be? Are there ways to facilitate a return to work sooner? They note that there are processes where often WSIB is out for a period of months because they're not the experts here, and then they can question some return to work. But did that come up much in the interviews, this kind of length of claims?
I think Basak would probably agree with me that we didn't really focus on the experience that employers had with the very longest duration episodes of disability. I mean, I think it is an important question that we really should start to think about, which is, given that the prognosis for not all, but an important fraction of workers disabled by PTSD who are first responders, given that the prognosis is unfortunately not optimistic, and it's a chronic condition, and recovery from it will take time, that I think we need to start to have a discussion within the services about what are the alternatives when it really doesn't look like it's going to be feasible, possible for a valued first responder to return to their pre-injury duties. What does that look like? These are very well-trained people, all of them, who've made a substantial commitment to public safety. Okay. But I don't think it's feasible to imagine that 100% of people are going to be able to get back to it.
Okay, so that leads actually to another question coming up from a couple of people in different ways. Is there discussion at workplaces about whether or not, the return to work accommodations, let's say, are going to be temporary versus permanent? So should supervisors and other leaders have an expectation that, in fact, it may be that some accommodations will need to be permanent? Or is there still a goal, a hope that this is a kind of temporary reintegration and the person would return to their full duties?
Basak, what do you think?
We did have, a number of conversations around kind of those challenges. And I think my understanding is, speaking to the employer representatives, it's really dependent on individual cases. So, and I think that was one of the important things that we heard in our interviews, like how complex and individualized return to work from PTSI is. So in a number of cases, I think the idea, like what we're hearing, the aspiration is to be able to bring people back to work through, reintegration, accommodated duties towards their, pre-injury role or in some level. But we did hear a small number of examples, like when there was a permanent, permanently they are not able to return to their pre-injury role or even to their profession. I think there are a number of programs where there could be a second career or retraining. So we heard that. So again, I think it really speaks to the complexity of this process, and also how individualized it is for workers, and especially if somebody's off work for a long time, because we heard that the workers might retire, or the communication is completely lost. So there's a lot of challenges around that. But in terms of, I think, answering your question, like, I'm not able to give a specific answer to a certain kind of process that the employers have, but I think it is more around individualized ways of trying to find these accommodations.
Thank you. I just want to remind people who may have joined a little bit late that the slides will be all available for you to go through. Is there a report or a manuscript published that is also available for people who want the findings? We've had some questions about that.
Sure. We do have a report, a summary report that speaks to, what I mentioned, presented today. So it's on our IWH website, and I believe that at the beginning of the presentation, Sabrina, or our team at IWH, already posted a link. And we are in the process of writing up our manuscripts, and when they are published, it's usually published on our IWH website for everybody to be able to access.
Okay, thank you. A couple more questions before we have to finish the hour.
Sure.
But a number of people have mentioned training for supervisors,
Yes.
specifically. And did that come up? Do you know of training that is available for supervisors to help them understand better the accommodation process and these kinds of injuries?
Yes. I cannot recall like certain programs or names of the programs or trainings, but definitely employer organizations talked about, at least some of them, training for supervisors and the importance of increasing the capacity of supervisors to understand mental health challenges, but also being able to communicate and interact better with the workers. Because I think because this was mentioned as a challenge also, and a need for more supervisory training. Some employers talked about like, having these trainings available for their supervisors or management. Yeah, because especially as I mentioned, like, there's the mental health stigma slowly diminishing within the organizations. But one of the things that we heard is while there was more of an acceptance and understanding of PTSI being an occupational injury, so, things are shifting that way. One of the things that we heard is there are a lot of uncertainties, especially for supervisors or coworkers, in terms of like how to communicate, how to support PSP who are returning back from work. So I think there are a number of trainings that are mentioned or initiatives that are more preventive in terms of increasing the capacity to recognize mental health challenges. And there are some programs also that are mentioned, like, attendance tracking and all these different programs that could help to initiate those conversations and supports. But also at the same time, I think they talked about like supervisor trainings in terms of like supporting return to work.
Okay,
And
thank you.
Monique, can
Yeah.
I just add one suggestion here? The Solicitor General, Ontario Solicitor General, is launching a program in April, about a 3-year program providing mental health supports for public safety personnel. And I think it would be useful to reach out towards the Solicitor General program to get some information on whether that program is actually providing a standardized training curriculum for supervisors around the accommodation and support public safety personnel with PTSD.
Okay, yes, thank you very much for letting us know about that. We'll see if we have time for maybe just 2 more questions. I know I'm firing these off at you very quickly. You mentioned prevention just a moment ago. Are there key elements that are being raised by programs? So it's not just responding to PTSI, but also to kind of look more closely at what can be done around prevention. Did that come up in the study much?
Yes, in our conversations with union representatives, association representatives, and the employer representatives, I think the conversations around prevention came up more in the context of there is a need to have more efforts and programs that focus on prevention. So in terms of, we heard the return to work programs being established and like, or in the way of being established. And I think our participants really recognized that creating more preventive supports, some of the programs and some of the activities that I mentioned in terms of like, being able to recognize mental health challenges early on, having access or being like, having access to mental health supports in a timely manner, and also increasing the capacity within the organization for more mental health supports, more resiliency training, for example, that was discussed as a need. So I think employers definitely do recognize that the shift that needs to happen towards more prevention, while also, of course, creating very like robust and consistent return to work programs. So yeah, we did hear about that kind of desire for having a more prevention focus shift. Yeah.
Okay, thank you. Maybe one more question just to finish off. At the beginning of the presentation, you noted, I think, Cam, that there was some formal evaluation of the mental health program that was conducted over 2022 to 2024. Can you just one of you speak briefly to that? And do you know if that's also available or published yet for others to review?
Okay. Here it is in a nutshell. So this was what we call a formative evaluation. We spoke with PSPs who had completed treatment. We spoke to the clinicians who provided treatment. The piece of work that Basak has described was also included in the formative evaluation. In addition, we did a empirical analysis of some of the treatment profiles of public safety personnel who went through the program. So, I mean, I think here's the punchline. The program started in November 2021. We were able to look at or observe treatment profiles for about 450 people who went through the program. The program had 3 distinct characteristics. It's very intensive. The outpatient program is very intensive. It's 14 weeks, about 3 to 4 hours of therapy time each week. It's a lot of work. It's a lot of work. Second thing is that first responders travel through the program in small cohort, other first responders disabled by PTSD. And the third component of the program is not by design, but by consequence, it was delivered virtually. So the clinicians and the first responders we spoke to who completed treatment all positively endorsed those 3 characteristics. It's intensive, the cohort model, and the virtual. What did we see in terms of treatment outcomes? About 25% of people who completed therapy had a positive, or had a reduction in symptom burden. About 25% seemed to benefit over the course of the 14 weeks of therapy. That's about what we see in clinical studies in North America related to the treatment of this condition. It's about what we see.
Okay.
So I think the final takeaway is the large majority of first responders who completed the treatment would recommend it to a colleague.
All right. Thank you very much. And we are out of time. However, I want to thank you both for such an engaging presentation, for all this information. Lots of great questions. So I want to let people know that the speakers will get all the questions, but please do reach out again to them, and they'd be happy to speak with you. I want to thank everyone for attending, and invite you to come back next month on March 25th, when we will have another IWH speaker series. The topic for that will be surveying the landscape of artificial intelligence use for occupational health and safety practice in Ontario and British Columbia. So thank you again, Basak and Cam, for a really terrific presentation. I hope everyone has a great day. Take care.